Bismillahirrahmanirrahim. Today's topic is shock. So, to start with, its learning objective. What we should know at the end of the presentation, it is definitely you have to define the shock, classification of shock. Most important, recognize the hemorrhagic shock sign and symptoms. And simultaneously, we have to explain the importance of early control of hemorrhage in trauma patients. And we have to describe the management and ongoing evaluation of hemorrhagic shock. So at the end, we have to list the components of the damage control, resuscitation, and finally, we will conclude all the different things which we have learned during the lecture. So start with, we can define shock as characterized by inadequate tissue, perfusion, and cellular hypofunction / hypoxia. So what happens? Total body cellular metabolism becomes malfunction, usually by inadequate delivery of oxygen to meet the cellular needs. So, although shock has been recognized for over 100 years back, but still we couldn't have a clear definition till now. So whatever is the cause, whatever is the etiology and pathological factors, and how many are the causes, but the common thing is, and the common denominator in all forms of shock is inadequate capillary perfusion, whatever is the cause. So if we classify the shock, so there are basically 4: hypovolemic shock, distributive shock, cardiogenic shock, and obstructive shock. These are the minor details of every shock. Hypovolemic shock to start with. This is the decreased preload due to internal or external hemorrhage. This is also called hemorrhagic shock, which we have to explain in detail. Other cause is dehydration. It can be burn or nephrotic syndrome, so in which we lose the fluid. Basically, whatever, whether it is bleeding or loss of fluid. So this is hypovolemic shock. And next comes distributive shock. Decrease in SVR with abnormal distribution of blood flow. So most common, it is seen in sepsis, anaphylaxis, carbon monoxide poisoning, and cyanide poisoning, neurogenic shock, which happens in the spinal cord, transaction partially or completely. There is an also important thing, cardiogenic shock, in which basically there is a pump failure and decreased cardiac output due to systolic dysfunction. Main causes can be cardiomyopathies, ischemia, dysrhythmia, congenital heart disease, right? So finally is the obstructive shock, in which outflow from left to right side of the heart physically obstructed. So main examples are large pulmonary embolism, critical coarctation, tamponade, and the tension pneumothorax. Okay. So as I already mentioned, we have to emphasize on hemorrhagic shock. So hemorrhagic shock is the reduction in the tissue perfusion flow, which is necessary to meet the metabolic needs due to inadequate perfusion, and inadequate perfusion is hemorrhage, which leads to hypovolemia. Major injuries in which a person can prone to hemorrhage are the vascular, solid organ, and the bones. In vascular, mainly aorta and vena cava, and solid organ, spleen, liver, and we can also include the kidney as well. Bones, major bones like femur and the pelvis. We have to quickly rule out blood loss through, like from chest. We have to get the chest X-ray and the fast scan. In abdomen, only fast scan is good enough. Pelvis, you need X-ray, definitely. And in femur, you have to examine clinically. Definitely there is a history and the X-ray as well. Now, see what happens with the fracture of associated of the long bones and the pelvis. Humerus and tibia, in which we can lose 750 ml each. Femur, 1500 to 200 ml, but not less than 1500 ml. Pelvis, it is always more than 3 liter. So these are associated soft tissue trauma as well, in which a release of cytokines occurs, which increase the permeability, and as a result, it magnifies the fluid loss. Already, we are running short of blood in the hypovolemia, and further, the release of cytokinins enhance the hypertension. What can be the confounding factors in response to hemorrhage? Patient age, that is extreme of age, is always affected more. Pre-existing disease like cardiac disease, and most important, medications as well. Suppose if patient is taking beta blocker, so he cannot enjoy the vasoconstriction which can occur and which should occur as a consequence of the initial blood loss. So that can misguide us. And severity of injury as well. And excess of care, that is very important, and duration of shock. And next comes the most important thing, which you will also see and learn during the presentation and at the end of the lecture when we conclude. Amount of pre-hospital fluid is very important, and the presence of the hypothermia. If we look at the pathophysiology of the hemorrhagic shock, what happens? Cardiac output, which is reduced in the hemorrhagic shock, it is the sum of heart rate and the stroke volume. And the stroke volume itself dependent on myocardial contractility, preload, and afterload. During the presentation, you will see how the myocardial contractility is affected, which leads to decreased preload and finally the afterload. Both increase and decrease in the afterload can affect the myocardial contractility. Initial response, first response after the injury, whether it is mild, moderate, or severe, there is a progressive vasoconstriction in the skin, muscle, and the splanchnic bed. Why it happens? Because you have to conserve the blood and give to the major organ. Okay? Simultaneously, important hormones are also released. They are catecholamines, epinephrine, norepinephrine. They increase the heart rate and the contractility and vasoconstriction. That is the initial response. Simultaneously, this vasoconstriction is also enhanced by the renin-angiotensin system, which releases the aldosterone and ADH, which conserve the water and the sodium. So it tries to increase the blood volume and the blood pressure, and urine output is also decreased. So these are the initial responses of hemorrhage. What happens if we look at the cell level? These previously we discussed loss in the major vessels. What happens? Definitely, shock develops when intercellular changes are observed. What happens? Inadequate perfusion to the tissue. As a result, cellular hypoxia becomes evident. So what happens? Aerobic metabolism becomes disturbed and it switches over to anaerobic metabolism, but at the cost of production of lactic acid, cellular edema, acidosis, and finally, again, if we have blood loss, this vicious circle continues, and finally, we lead to the lethal triad. We will also discuss what is lethal triad. in the next slides. So this is happening at the cell level. How you can assess the hemorrhagic shock? Classic symptoms of the shock. If you come at the scene, if you met the patient, these are changing mentation, tachycardia, as we already discussed, cool, clammy skin, prolonged capillary refill. Usually it is less than 2 seconds normally. If it is prolonged, so this is a sign of shock. Narrowed pulse pressure. So usually it is 30 to 40. So finally it becomes 30 to 10. So decreased urine output and hypotension. If we look at the ATLS classification, this can also help us, provided you are able to calculate the blood loss. There are 4 classes. So class 1, in which it is less than 750 ml or 15% of the total blood loss. In heart rate is less than 100. In class 1, there is no compensatory changes. And blood pressure is normal. Pulse pressure is also normal. Respiratory rate remains almost normal between 14 to 20. Urine output is more than 30 ml per hour, and the CNS slightly anxious. But in class 2, the blood loss is 750 to 1500 ml, that is 15% to 30%, and heart rate is more than 100, the initial compensation. Blood pressure is almost normal, slightly diastolic may increase as a compensatory, but it is not necessary. And pulse pressure decreases. Respiratory rate 20 to 30, slight increase in the normal respiratory rate. Urine output becomes 20 to 30. And CNS, mild anxiety. In class 3 and class 4, if you look simultaneously, the blood loss is less than 2000 in class 3 and more than 2000 in class 4. Heart rate more than 120 and more than 140. Blood pressure in both conditions, both classes decreases. Pulse pressure also decreases. Respiratory rate 30 to 40 in class 3 and more than 35 definitely in class 4. Urine output class 3 we can have, but very low, 5 to 15. But in class 4 this is negligible. And anxious and confused in class 3, confused, lethargic, and sometimes unconscious in class 4. So keeping all these things in mind, so we can manage the patient. Now look at assessment versus resuscitation. So in which we have to see what was the traditional way of the treatment and what is new. What are the new guidelines? What are the new evaluation? Acute versus ongoing loss and static versus dynamic changes in the monitoring system, and global versus end organ as a whole change or individual end organ change, in which we have to see the mentation, skin perfusion, pulse, blood pressure, pulse pressure, shock index, what is shock index? We will see in detail in later slides. Urine output. Now, the rest of the things are very important. pH, serum lactate, and the base deficit, and the temperature as well. So these are the component of the lethal triad, which I have already mentioned, and I'll discuss in detail later on. Echocardiography, what are the cardiac effects, and arterial wave analysis, and finally is the STO2, muscle oxygen saturation. So to start with, we have to see the response fluid resuscitation, in which we have to evaluate vital signs, estimated blood loss. There are 3 categories. 1/3 in which you get the rapid response and another 1/3 in which there is a transient response, and the last category in which we don't have any response. So in the first category, the vital signs return to the normal with fluids, and estimated blood loss is minimal, 10 to 20%. And usually you don't need further IV fluids, and the need for the blood, if it is very low, so if it is required, you have to cross match and blood typings. And or possibly something can be hidden in later stages. You require the operation theater. In the category of the transient response, there is only transient improvement. And it means that there is some hidden loss or there is ongoing loss, which can further deteriorate the condition. So this is moderate and ongoing blood loss, 20 to 40%, and need for IV fluid is very high. Or if blood is required, yes, there is a moderate requirement in a type specific, and OR is most likely. But in the last group, there is a definite you need operation theater, and vital signs they remain abnormal, and severe blood loss more than 40%, like grade 4. According to ATLS classification, fluids are required, and immediate you need a blood, and which O positive for the males and O negative in the pediatric group and the female of the childbearing age. The value of the manual white signs, pulse corrector and GCS motor verbal, it all affects, and it matters a lot. Okay. There is a rough estimation from the pulse. If you look at the picture, carotid, if you feel the carotid, so you can estimate that it is 60 systolic blood pressure. In the radial, if you can feel the radial, almost 80, and in the femoral, it is 70, and dorsalis pedis, it is the 80 millimeter of mercury. This is a condition of occult hypoperfusion. Apparently, there are normal physiological criteria. Pulse and blood pressure are normal, but patient is still in this state of the decreased oxygen delivery. So, and these patient deteriorates immediately. One diagnosis, perfusion is very important. Pale, watered vasoconstriction, I think, in which patient is a state of initial compensation. Most sensitive in pediatric patient. It starts from the distal extremities and then ascends towards the trunk, and capillary refill. Although it is unreliable, but one should go for it. One should go for the check. Normal is less than 2 seconds. If it is more than 2 seconds, this is definitely significant. Blood pressure. Blood pressure responds to the volume response. Usually it is non-linear due to compensatory mechanism. Insensitive signs of early shock. In some study, systolic blood pressure did not decrease less than 90 unless base deficit is more than 20. We will discuss what is base deficit and how it affects in the later slides. Infrequently or inadequately monitored. First, blood pressure should always be manual. Try to, because there is always overestimation in the automated blood pressure. Systolic blood pressure drop in a late stage. Systolic blood pressure doesn't fall until there is a blood loss. In adult is 30%, and in pediatric group 40 to 45% blood loss. And systolic blood pressure less than 90 millimeter of mercury it is the indicator for the 65% mortality. So we have redefined the level of hypotension. The new hypotension level is less than 110 millimeter of mercury of systolic blood pressure, associated with the onset of the physiological changes. What happens? There is an increased base deficit. It increases the ICU days stay, ventilator days, and any complications. So it is used only to diagnose the shock, not a resuscitation endpoint. So as we previously discussed, new systolic blood pressure is defined in adult trauma is 110 for the adult, and in geriatric trauma it is 140, because in geriatric group of patient there is also a cardiac problem and the decreased cardiac activity, decreased systolic function. So that's why we are taking 140 systolic blood pressure as the criteria. Pulse pressure, as we already mentioned, the narrow blood pressure, the pulse pressure is also indicative of the blood loss. Normal is 30 to 40. Very important things. We have to calculate the shock index. Shock index, it is the ratio of the heart rate to systolic blood pressure. So it elevated early in the shock. The normal value is 0.5 to 7. So when it goes more than 0.9, so it predicts acute hypovolemia, and it is a marker of injury, severity, and the mortality. So it is also used in the pre-hospital use in trauma and triage, which patient should be preferred to shift or resuscitate. Urine output, that is very important. Adult, this should be 0.5 ml per kg per hour, child 1, toddlers 1.5, and the infant 2 ml per kg per hour. There are different hemodynamic monitorings in which intravenous pressure and pulmonary artery. Both of these have no major role in the hemorrhagic shock, although they have their own significance. But the Doppler echocardiography, this is more important as a diagnostic tool, not as a monitoring device, but as a diagnosis, because we can estimate the ventricular function, volume status, stroke volume, and the cardiac output. But it again, it is dependent on the technology investment. Definitely, it is an expensive thing, and technical expertise are required. Arterial veil pressures, yes, this is important. You can calculate the stroke volume variation and the pulse pressure and filling. Another is most important and the most latest thing is skeletal muscle saturation. It measures hemoglobin, oxygen saturation in the tissue. Otherwise, what we measure through SpO2 in the blood of the arterial blood. Okay? So actually that helps to, it can help to see the delivery of the oxygen. So if it is not good, so it can predict the mortality, research ongoing, and resuscitation endpoint. And that is very simple as well, and non-invasive as well. Hemorrhagic shock. What about the lab values? Definitely hemoglobin, hemocrite, very important, but don't waste time to wait for the investigation. You have to manage clinically if there is delay in the reports. Arterial pH. So this is very important. Normal is 7.4. So if it is less than 7.2, so these are ongoing markers of the severe physiological derangement. So it can affect the cardiac contractility, cardiac output, vasodilatation, and decreased blood pressures. And the last consequence is decreased hepatic and the renal blood flow. Lactate level. Although it is indirect measure of oxygen depth, normal value is 1 milliequivalent. Values more than 1 correlate to the magnitude of the shock. Lactate level more than 5 increase mortality, and one should have the ability to clear the lactate within 24 hours. This is a good predictive of the survival. But if you are if you cannot clear within 12 hours, this is predictive of multi-system organ failure. Base deficit. This is a very sensitive measure of inadequate perfusion. Normal range is -3 to +3. So we can take it from the blood gas and admission. One should know the baseline base deficit at the admission of the time, and in the series we should go for the base deficit. Ongoing bleeding, inadequate volume replacement is very important. So another thing is INR, International Normalization Ratio. So they can talk about the extrinsic pathway, internationally accepted method of reporting prothrombin time. So INR is derived from the PTT and APTT level. These are the normal and the deranged ranges. Another good thing is thromboelastogram, although this is not available in our country or in our city. So if you look at thromboelastogram, this is the graph. There are different things in which we can see the thrombosis and the fibrinolysis. There are different components: R time, K time, alpha angle, and maximum amplitude lysis time. What it helps by saying this, if all these things, R time, K time, alpha angle, and maximum amplitude, if these are deranged, so we can exactly know what is required, what blood component is required. So instead of giving whole blood, this can tell you at this time, you need only platelets, either FFP or a combination or a cryoprecipitate or a whole blood. So it tells you individually. As I already told you, it predicts the needs for transfusion or the blood component. So we can also assess low molecular weight heparin monitoring in high-risk ICU patient. The only method for detecting degree of anticoagulation by other coagulants as well. Finally, after the diagnosis, we have to go towards the treatment. How we should treat? Airway, breathing, and circulation, the basic thing. To start with, when you are maintaining airway, don't forget the pneumothorax, because patient might not have lost so many blood or massive hemorrhage, but he is having hypertension. Pneumothorax can be the cause, so we should look right in the beginning. There are mechanical means of stopping hemorrhage, like pelvic binders reduce the pelvis volume, tamponade effect, and we can also use tourniquets in different areas where it can be applied. Okay, what is the most important IV access principle? What should be there? Take it fastest, simplest route, best. That is antecubital. Large bore, short length, 14 to 16 gauge, 2-inch length is required, and flow limited by the IV gauge and the lens, not size of the vein. So how we should go with? Optimally, 2 people attempt simultaneously, and 2 different sites, 2 of the 3 sites required per major trauma. So we can progress to peripheral IV line to femoral and finally to subclavian. So consider intraosseous IU if the peripheral lines or any you cannot access to the any major vein. So this is also a rescue device. Simultaneously, we have to avoid IV access in the injured limb and distal to the possible vascular wounds and femoral access with injury below the diaphragm. IV access in shock, femoral vein, and subclavian and interneural vein. So preferably we should go in progressive manner. How we should go for the intraosseous device because everybody is not familiar with it. This is a temporary access uh, provided you cannot have any access to the other IV access. So children and adults insert within 1 minute. It can be inserted manually or with a power drip. What can be the site? Proximal tibia, humerus, and the sternum. So try to avoid it in the fractured limb. Good for the fluid and the medication. And extravasation is the risk. Another important thing is pre-hospital IV placement in trauma. No evidence to support IV placement at scene. One should not waste putting IV line at the placement at the scene. It should be limited. If it is required, it should be limited only the 2 attempts. So avoid continuous IV fluids. Use small boluses if required, 250 cc. We will see later on in the protocol of the fluid. Okay, you have maintained the IV line. Then what should be the choice of the fluid, whether normal saline or the renal lactate? Yes, you can get the normal saline, but there is a danger of hyperchloremic acidosis. And the good choice is the lactated ringers because it contains sodium, chloride, potassium, calcium, lactate. And this is a fluid of choice. And ATLS, we can go for ringer lactate. Small volume resuscitation using hypertonic. Small volume means when you give the small volume and get the results as you have given the more fluid. Using hypertonic, hyperosmotic fluids, so remains in the vascular space longer because the crystallites like ringer lactates and the normal saline, after some times, they leave the intravascular space and go to the extravascular in the tissues. The main idea at this moment is to restore the vascular volume. So the small volume resuscitation can be done by the plasma volume expanders. There are different plasma volume expander which are available in the market. So it is the 500 ml is equivalent to 2 to 3 liters of the ringer lactate, but one should not exceed more than 1.5 liter or maximum 2 liter because it can affect the coagulation. Another thing is the hypertonic saline. So we have 3% to 7.5% sodium chloride. So how it works, it rapidly pulls fluid from the tissues into the bloodstream and stabilize the blood pressure and the cardiac output. We should consider by if we are continuously giving the fluid because it doesn't carry oxygen or it doesn't clot. So one should take care and one should be able to know when to stop the fluid and start the blood. What are the choice if you have to give the blood? There are 3 things: packed red blood cells, plasma, and the platelets. in the packed cell, it carries the oxygen, and the plasma, it has the coagulation factors, and platelets, the concentrate of the platelets. So the 1 unit contains the packets at 300 ml of the total volume, and it increases the hemoglobin by 1 gram and hematocrit by the 3%. If we look at the plasma, increase the coagulation as a whole by 2.5%, and platelets, they increase 25,000 to 50,000 per unit. And one should be very specific and careful about the storage. Blood administration, previously in the traditional management, we used to give the fluids at least 2 liters, and then we also used to continue the IV with wide open. And later on, we used to think about the packed cells. And then after giving some packed cell, we had to wait for the labs, and then we used to decide whether it should be given plasma or platelets. But now the emerging management or the latest management, fluids should be minimized. One should go for the blood, that is plasma and the RBC, either in 1:1 or 1:2 ratio. And after this, we can activate the massive transfusion protocol and the system. What is massive transfusion? So in old days, it was 10 units packed red blood cells within 24 hours. But then now, new definition is 10 units of packed red blood cells within 6 hours. Blood progression in hemorrhage. So this is divided into 3: immediate, 10 minutes, and the 5 minutes. If it is immediate, immediately required uncross-matched blood, males, they need only O positive blood, but we have the restriction in the females of childbearing age and the peds and pediatric groups with O negative. And if it is required 10 minutes later, it should be type specific. And after 10 minutes, in the more than 50 minutes, we definitely need a cross-matched blood with APO and RH type antibodies. The protocol for the massive transfusion protocol. So we have to optimize oxygen, cardiac output, and simultaneously monitor every 30 to 60 minutes. And the aim is maintain the temperature more than 35 degree, pH more than 7.2, and base 6 is -6. So is there any role of the drugs in the hemorrhagic shock? Yes. It is recombinant factor 7A. So it is given in the refractory bleeding in the trauma. Before giving it, you have to correct the hyperphosphatemia, give cryoprecipitate, and thrombocytopenia, give platelets, and you have to correct the temperature and the acidosis as well, because it doesn't work in the condition of acidosis. So it includes in massive transfusion protocol, but it should not be used in the too early stage or the too late. It can be repeated at 1 to 2 hours intervals if required. Another thing is tranexamic acid. As compared to factor 7A, it is inexpensive, and there are different studies in which we can get the good results. In some situation, soldiers are supposed to carry auto injection during the battlefield, in which they don't, when they are not provided by the immediate medical care, they can give by themselves with auto injection tranexamic acid. What it is? Hemorrhagic shock. What are the evolving treatment concepts? Yes. Look at this a lethal triad or trauma triad death. There is a vicious circle of hypothermia, acidosis, and the coagulopathy. Our aim is to break this vicious circle at any level, maintain good temperature, uh, avoid acidosis and coagulopathy. If we are unable to break this vicious circle, we cannot get out of it. Hypothermia, core temperature when it is less than 35 degrees centigrade. What it affects? Because it decreases the coagulation factor and increase platelet dysfunction. Acidosis, it affects the altered hemostasis and myocardial depression. And with increasing acidosis, that is less than 7.2 pH, base deficit is more than 6. It predicts that transfusion, increase ICU days, and risk of the multi-system organ failure. Now, what are the changing paradigm? Traditional versus the damage control. Traditionally, all resuscitation used to be done in the emergency department, and then patients used to bring in the OR. It was not a good outcome. Now, by evolving the damage control system, we do simultaneously resuscitation and the treatment. In emergency department and the OR, patient is transiently shifted in the ICU for the further management, and later on for the definite surgery. Again, patient is brought into the OR and finally to ICU. This is the 3 stages. Stage 1, initial control of the hemorrhage, as we already discussed. Stage 2, stabilization, and stage 3 is the definite surgery. So these are the variables of damage control resuscitation. Permissive hypotension, just we have to touch the physiological endpoints. Don't try to correct the numbers. Avoid popping of the clot. Mean arterial pressure is decided in the absence of traumatic brain injury, 50 to 60 as a resuscitation target. So according to new treatment paradigm, resuscitate and stop the bleeding. This should be the main idea. So if we look at the component therapy versus whole blood, definitely component therapy is more effective. So if we put all the factors, all the management strategies all together, what we can conclude? Most important, pre-hospital fluids, as I already mentioned in the early. So penetrating, if the wound is penetrating, but the patient is stable, so no fluid is requirement. Just go with the pulse. If it is penetrating and unstable, try to 250 ml pulses and go for the radial pulse. If it is traumatic brain injury, try to take only 250 ml boluses and try to maintain mean arterial pressure more than 60. What patient is at risk? We have to identify high injury score and shock index more than 9 and systolic blood pressure less than 90 millimeter of mercury. Acidosis and base deficit more than 6, we have already gone through it, and hypothermia, decreased INR, and elevated lactate. So we require lab for the major activation. So finally, at the end, putting it all together, hemorrhage, but without traumatic brain injury, maintain systolic blood pressure between 80 and 90, and traumatic brain injury, here we need systolic blood pressure more than 90 just to make the cerebral perfusion. If it is a combination of hemorrhage plus TBI, Still, we don't have any recommendations. So finally, at the end, what we have to do, we have to assess for the coagulopathy very early. The key point. Ringer lactate is the fluid of choice, but you have to restrict where you have to restrict, already mentioned. And don't hesitate, go for massive transfusion protocol. Small volume resuscitation technique is also advisable. We can prevent the coagulation disorders. Consider tranexamic acid and the factor 7A, correct acidosis and hypothermia. And ultimate aim is stop the bleeding. Thank you very much. Any questions? Please do mention.